I would like again to thank everyone in the organizing committee for this very nice meeting. Actually الحضور هايل امبارح والنهارده والشركات ما شاء الله كثيره يعني very well organized. بشكر دكتوره ماري على الدعوه الكريمه for this meeting. And for sake of time, I will start immediately. So our topic today is, my topic is to give you an idea about amyloidosis and how can imaging in general help in diagnosis of cardiac amyloidosis. And my objective today is to give you an idea about the different types of amyloidosis, the AL type and the TTR type, and to give you an idea about the different modalities that can help in diagnosis of amyloidosis, like nuclear scans and cardiac MRI and echo and other exams. So, broadly speaking, we have 5% of the causes of amyloidosis are due to some very rare condition like serum amyloid A and apolipoprotein A1 and others. But the main two topics, the two main causes of amyloidosis that are important for us are the AL type, which is the amyloid light chain type, and the ATTR type, which is the amyloid trans-serratin amyloid type. And this ATTR type is furthermore subdivided into two types, the hereditary type and the wild type. The wild type is the most common that we see in elderly population. And why it is important to highlight for the diagnosis of amyloidosis in 2024 and 2025, because if we are able to differentiate these two types and if we are capable of diagnosing the TTR type, actually will be saving life, because now there is a treatment for the TTR type. And actually, this category of patients are very can die from heart failure very easily in 2 to 3 years. And if we are capable of early diagnosis of the TTR type, we can give them a targeted medication, and it can be life-saving. Amyloidosis is a difficult disease to diagnose. That's why we brief it in the form of hidden for H for heart failure, I for intolerance to medications, D for discordance in the ECG, which has a pseudo-infarction-like pattern. Diagnosis is usually difficult, and we can have lumbar spine stenosis. We can have bilateral carpal tunnel syndrome, which is very common in cases of amyloidosis. Echo and MRI can give us a very important clue in cases of amyloidosis, showing us this infiltrative pattern within the interventricular septum, giving a granular texture in echo, like you can see here. And the N is for nervous system, with a lot of manifestation like polyneuropathy, autonomic dysfunction, and GIT unexplained symptoms. If in last few years we were speaking of 3 main modalities for diagnosis of amyloidosis, as you can see in this paper from radiographics, and we are speaking of mainly echo and MRI and isotope scan, mainly focusing on the heart and on the brain. And yes, in the brain we can detect the amyloid plaque using special PET-CT, amyloid PET-CT. As you can see in red here are the amyloid plaques. But now, with recent advances, we are detecting amyloid plaques everywhere else, in the liver, in the orbital region, in the heart, as we will explain, and in the gastrointestinal system. So, if we want to diagnose amyloidosis, we can start by some labs like biomarkers, BNP and troponin. ECG will give us a pseudo-infarct pattern, as we have said. Echo and MRI will have in common showing us a big heart with some biatrial enlargement, second interatrial septum. Additionally, the MRI will have some very high T1 and T2 mapping values and high ECV values, as we will explain in the remaining portion of the lecture. And then we can confirm the TTR type that we are looking for using a nuclear scan, bone scintigraphy. We could go for a cardiac biopsy, and genetic testing would be important to differentiate the 2 types of TTR, the wild type and the H type. Coming to MRI, yes, sure, MRI is the gold standard technique now for assessment of any infiltrative disease, as nicely explained by Dr. Arim in the previous lecture. And this is to summarize her lecture in one slide. So we start by some black blood imaging, then some white blood imaging in short axis and 4-chamber view. Then we inject contrast. We wait 10 minutes. And we go for the late gadolinium enhancement cuts. And what is very important are the T1 and T2 and the ECV cuts. So this is the protocol very shortly. And then we use the T1 mapping to detect interstitial fibrosis. I will not repeat the lecture of Dr. Arim. T1 mapping values can vary from on 1.5 Tesla machine and 3 Tesla machine. This is very important. And in cases of amyloidosis, as you can see here, we'll have in both types, the TTR type and the L type, we will have very high values, أعلى من 1200 milliseconds. So it's very important to look at that. And this is an example of infiltration. And in case of amyloidosis, in yellow, you can see the amyloid deposition within the heart, which is thick, as you can see, and enlarged, and with an increase in LV mass. And this is a normal heart with a normal myocardium, as you can see in green in cases in T1 maps. T2 maps are very important. They are always to be linked with the T1 mapping values. And in cases of AL type of amyloidosis, the T2 mapping values will be high and will be above 50 to 60. So this is mainly above 60. So this is an important biomap to be performed in all cases of suspected amyloidosis. Then we can perform what we call the ECV, the extracellular volume calculation, which represents a ratio between the uptake of gadolinium related to the hematocrit value of the patient. And again, the ECV maps will be very high in cases of TTR. TTR is the one we want to detect. TTR is the one that we want to diagnose because there is a treatment for the TTR type. Then, so it's very important to remember that we have these 3 non-invasive stars in MRI, the T1 and the T2 mapping, the T1 for the fibrosis, T2 for edema and broadly, and the ECV for calculation of values, which are very high in cases of TTR, as we have said. I will not go through the different pattern of enhancement in cases of cardiac MRI examination, but in cases of amyloidosis, we are speaking of a diffuse subendocardial pattern of enhancement, which is rather characteristic. And this is and here is an example that was performed in our institute. And you can see here that we have in late gadolinium enhancement cut a bizarre pattern of enhancement, this greasy appearance, and typically we have pericardial effusion and pleural effusion, which are very typical in cases of amyloidosis, I must say. Otherwise, we have a very sick myocardium, as you can see. And to sum up these slides, the two most important cuts to look for are first the late gadolinium enhancement cut, and second, if we must look at the T1 mapping value. As you can see in this case, the whole T1 mapping values are very high. This case was performed on a 1.5 Tesla machine. So, what is the differential diagnosis? The differential diagnosis is, of course, cases like cardiac sarcoidosis. Typical here, we have lymphadenopathy, we have hepatosplenomegaly, we have mixed pattern of enhancement, epicardial, subendocardial, transmural. This is one of the differential diagnoses for cases of amyloidosis. And the second differential diagnosis is hypertrophic cardiomyopathy, where the LV mass is increased, and we can have LVOT obstruction, systolic antiomotion, and all the associations that are in cases of hypertrophic cardiomyopathy. But again, here the pattern of enhancement is totally different than in cases of amyloidosis, and the T1 and T2 mapping and ECV values are totally different. So, to try to sum up again, because it's very important to remember that we have a generalized increase in T1 and T2 mapping in cases of amyloidosis. We have a characteristic thickening of the atrial septum, more than 6 millimeter is very characteristic actually, and we have an increase in the LV mass, and we have more specific sign like the zebra or the ground glass pattern of enhancement in late gadolinium enhancement. The transmural enhancement is more common in TTR type. Don't worry, I will resume everything at the end of the lecture. And we can have some apical sparing. T1 and T2 mapping values are higher in AL type, and ECV values are higher in TTR type. This is the typical pattern of enhancement. We have a non-suppressible myocardium signal on late gadolinium cuts, which is characteristic. So يعني to make it short الفني بيطلع عينه علشان يقدر يعمل البوست كونتراست انهانسمنت كاتس وما بيقدرش ان هو يعملها بسهوله وبيضطر يعلي الفاليوز بتاعت الانفرشن كارفي تايم بتاعته a lot and بيبقى very difficult examination for him actually. One of the important signs as well, I had this case just 10 days ago, actually, is the sherry on top. And actually, this is an echo finding, actually. And the whole myocardium is actually not contracting well, apart from the apex of the heart, which is contracting well. And you can also see this in the pattern of enhancement, sparing the apex of the heart, and the mid and the basal portion of the heart are showing the typical subendocardial pattern, which is characteristic for cases of amyloidosis. So to resume, if I have a case of cardiac amyloidosis, my role is to differentiate between the AL type and the TTR type. So for the TTR type, we have this important pattern of enhancement, and we have this high ECV values which are typical. And for the AL type, we will have the high T1 and the high T2, as you can see highlighted in red. So you can see that the 3 stars are really helping us in diagnosis and differentiating the 2 types of TTR and AL type. And by diagnosing and confirming our diagnosis of TTR, we can then start treatment after confirming this diagnosis by doing a nuclear scan. So we must go for a nuclear scan, we must go for a pyrophosphate, technetium pyrophosphate examination to confirm the TTR type, which is actually usually in cases of TTR are highly avid, as you will see in the next 2 slides. So this is the 1-hour approach. You can see in this nuclear scan that the heart is having an uptake higher than the ribs, and after 3 hours we will have this characteristic grade 2 or grade 3 pattern of uptake, where the heart is uptaking the pyrophosphate, the technetium pyrophosphate, much higher than the adjacent ribs, which is characteristic for the TTR type. Then, if we have the possibility of going for a biopsy, you can go for a genetic for a biopsy, which is rather difficult in Egypt. And I want to end my lecture by the debate, the famous debate. So, as you can see in this paper published 5 years ago, they are mainly focusing on echo and mainly focusing on nuclear scan for screening and treatment and diagnosing cases of amyloidosis. But the question, where is MRI? This is the really important question. If we look in literature, in this paper published 5 years ago as well, they are speaking and saying non-invasive imaging methods, including echo, bone scintigraphy, and cardiac MRI. Notice that the cardiac MRI is the last portion and the last written examination in this paper. They are not giving enough importance to the MRI. I don't know why, actually. This is the first issue. If you look at this second paper published by famous Sanjibala in radiographics, I think 4 years ago. Again, they are speaking of the importance of MRI, and here MRI is gaining more and more importance. Okay, this is good. If we look at this final paper just published last year in the JACC, it's very difficult to find MRI, but if you look carefully, yes, they are trying to introduce MRI as a good screening technique. And actually دي الحقيقة this is our experience خلال السنة الماضية. يعني حالات كتيرة ايكو بتبقى جاية بهايبرتروفي ومنبقاش عارفين السبب ايه، وبنعمل MRI وبنكتشف. احنا اكتشفنا تقريبا خلال السنة اللي فاتت من 12 ل 16 حالة، which is a big number الحقيقة، ولدرجة ان احنا ابتدينا نسجل رسالة في هذا الموضوع. So it's very اعتقد ان MRI has a very important role and must be emphasized more and has a very important role in screening cases of amyloidosis. أنا سوري زودت يعني هاخد دقيقة واحدة بس وقت زيادة، أنا خلصت. طبعًا ال AI will be helping a lot في الكالكوليشنز بتاعت حالات الكاردياك MRI T1 و T2 mapping وال ECV وال synthetic ECV. So AI will be helping us a lot. And my conclusion, I think a combination of a complete multi-parametric MRI examination, including T1 and T2 mapping and ECV and AI, will be helpful a lot to detect a lot of cases of TTR. ومعظم الحالات اللي احنا قابلناها خلال ال 12-15 حالة اللي كنت بتكلم عليهم كانوا معظمهم TTR الحقيقة. ف it will be really helpful for this category of patients. And thank you very much.
Thank you very much, Professor Ahmed, for this informative lecture about amyloidosis.